My name is Camilla Schele, and I'm an associate professor here at CBMR. And it's my great pleasure to introduce our next speaker, Amalia Gastaldelli. She is a research director at the Institute of Clinical Physiology, CNR, in Pisa, where she leads the cardiometabolic risk group and the multi-omics mass spectrometry laboratory. She's a very interactive and very wanted person as well. So she's also an adjunct professor of medicine at the UT Health San Antonio in Texas, and an affiliate professor at the St. Anna School of Advanced Studies in Pisa. Her research focuses on the pathophysiological mechanisms of metabolic diseases, particularly MASLD, obesity, and type 2 diabetes, with a special emphasis on metabolic fluxes and hormone regulation. And as president of both the European MASLD study group and the EAGER study group, she has played a key role in advancing research and clinical guidelines. And today she will share her insights on glucose and lipid metabolism in MASLD. So please welcome Amalia.
Oops. Well, thank you very much for the kind introduction, and it's a pleasure for me to be here today and to talk to you and to show you what we are doing in my lab. So these are my disclosure. First, I'd like to start my talk with the history of this nomenclature for MASLD is also because it has been recently changed. So back in 1980s, that Ludwig found this a lot of fat in the liver and named this disease NAFLD, so non-alcoholic fatty liver disease. And the diagnosis was mainly an exclusion diagnosis, so they didn't have to excess alcohol consumption, no other secondary causes, no viral. And this is, of course, divided in simple steatosis called NAFL or steatopatitis called NASH. And then they started recognizing the metabolic influence in this disease. And the first two, there was a consortium that defined this as a metabolic dysfunction-associated fatty liver disease and was muffled with the F. And this was finally an inclusion criteria. And so if the subject had the steatosis and they were lean or with normal weight, so BMI less than 25, with at least 2 cardiometabolic risk factors, the one from metabolic syndrome, or if they were with overweight obesity, BMI greater than 25, or type 2 diabetes. But in this definition, there is no mention about alcohol intake. And then we went to the more recent nomenclature, that is metabolic dysfunction-associated steatotic liver disease, so MASLD with the S, that also has a completely different one. It has a liver steatosis with at least 1 metabolic risk factor, no more 2, and also isolated steatosis or steatohepatitis, same definition as the NASH, so there is no change there, very important for the new drugs. And also there is this new category that is MASLD, that is MASLD with an increased alcohol intake. But I have to tell you that the MASLD is not obsolete, because there are countries like the Northern Africa, Middle East, and especially the Australia, New Zealand that still keep this definition, while most of the other countries, they use MASLD. And what is including MASLD? MASLD includes simple steatosis, muscle, but also MASH and cirrhosis. So when you talk about MASLD, is everything with steatosis and those metabolic criteria, and it could be subject with MASH, because for MASH you need a liver biopsy. This is still the only way to diagnose MASH. And the question is, who is at risk? And the estimated prevalence is in general population 38%, but the diagnosis of MASLD remains incidental in the general population. That means we don't look for subject with MASLD. Instead, we look for subject at risk of MASLD and at risk of fibrosis, because fibrosis is the one criteria that is associated with the worst prognosis, not steatosis. So all the guidelines now are saying that subjects at risk that are obese and with type 2 diabetes or other causes, that should be screened for fibrosis. And why? Because mortality MASH is closely tied to fibrosis stage and not to steatosis. So this is the reason. And also to talk about the prevalence, subject with obesity, prediabetes, and also with metabolic syndrome are the great majority, even if we have subjects with MASLD and that they are lean. And the global prevalence in type 2 diabetes of MASLD is 67%. So 2 out of 3 subjects, they have a MASLD and MASH. MASH is 41%, so really high. And advanced fibrosis, so it is fibrosis at 3 and 4, there are 4 stages of fibrosis, is about 38%. So this number really are terrible, and we need to look for these subjects. And you see here how obesity and MASLD, they really go together, and they have the same projected prevalence. So in the pathophysiology of MASLD, what we should look, there are several causes. It could be genetics, unhealthy diet, gut dysbiosis, but of course, you know, the most important, we need to look at obesity, especially abdominal obesity, and we need to look at diabetes. So we need to focus on lipid and glucose metabolism also. And I start with lipid metabolism, and I would like to guide you, you know, through what are the abnormalities that we find in this subject with MASLD, but especially in our cohort, we study subject with MASH, so with the liver biopsy, with different degrees of fibrosis, and I think this is the unique things of our population, because usually you find data only of subjects that have been screened for steatosis, especially, you know, with the imaging, but we don't know enough about subjects with advanced MASH and fibrosis. And to do this, we use also some fluxomics analysis. What is fluxomics? We infuse metabolites labeled with isotopes, stable isotopes, so non radioactive. Usually is deuterium, but it could be C13. And by infusing, for example, glucose, glycerol, or leucine, we can measure glucose fluxes, lipolysis, VLDL secretion. This is in vivo in humans, and this is very safe. And with deuterated water, that is a drink, we can measure de novo lipogenesis and gluconeogenesis. And of course, we need a mass spectrometry to measure all these things. So I will not go through the techniques of mass spectrometry, but you'll know that these techniques are based on mass spectrometry. And these are some of the initial data we found when we started. And these are subjects that were non-obese. So the BMI was below 30, and they didn't have a metabolic syndrome. They didn't have the 3 criteria. But you see here, this is a clamp with 2 steps, so a low dose and a high dose. You see that first, this is the lipid things. The plasma free fatty acids are higher in subject with MASLD, but also the lipolysis that is measured with the tracer is high. Very similar, the two things. What was surprising is the lipid oxidation is high. So it's not that they have a steatosis because they have a defect in total lipid oxidation. This is coming from indirect calorimetry. And this is beta-hydroxybutyrate that is a marker of hepatic oxidation, still very high. So this is because the excess of fat is burnt, probably not enough, and they still have a deposit in the adipose tissue. This is also adipose tissue insulin resistant, because despite the insulin, they cannot suppress enough all the free fatty acids. So this is called adipose tissue insulin resistance. But also the adipose tissue is secreting not only free fatty acid, but also pro-inflammatory cytokines, and is reducing the anti-inflammatory adipokines like adiponectin that is related to fatty acid oxidation. And so to measure the adipose tissue insulin resistance, we use now this very easy index, not based on fluxes, so everybody can measure. This is a sort of HOMA of the adipose tissue, and is measured by free fatty acid times insulin. And why is this? You have seen that there was a dose response in the previous slide that is a sort of hyperbolic curve. So this is the justify this formula. So the product of free fatty acid times insulin give an idea of insulin resistant state, because despite high concentration of insulin, you have high concentration of free fatty acid, and you see how the curve are moving to the right as subject becomes insulin resistant or diabetic. And these are some of the data on this adipose tissue insulin resistance index published by our group, but also by others. You see that there has been showing, this is an Amsterdam group. They show that there is an increase not only in subjects that they have steatosis without diabetes, but also with diabetes and NAFLD. But if a subject has diabetes without steatosis, the adipose tissue insulin resistant was not elevated. These are the study we published in MASH, so with the liver biopsy. And you see here that with respect to control, the adipose tissue insulin resistant index was 4 times higher. And these are the data in diabetic. So you see how the subject becomes, as they become intolerant and with different degrees of fasting hyperglycemia, the adipose tissue insulin resistance is increasing. And these are data with instead the clamp that they show here. Let me just move my and you see here the suppression of the adipose tissue that is impaired as subjects have a higher content of triglycerides. And these are data, some of these they are unpublished. The one that we study a cohort with 80 subjects, all with liver biopsy with different degrees of BMI, where we measure lipolysis and glucose fluxes, and also the adipose tissue insulin resistance. You see here has lipolysis is going up with BMI, but it has the same trends and the adipose tissue insulin resistant, to confirm how this simple marker can be used also to as an index of lipolysis. But this are the data that instead has just been published in some reports in medicine. Adipose tissue insulin resistance is going up with fibrosis. So subjects that have the MASH and with the fibrosis 0-1, so like no fibrosis, have the lower, very similar to MASLD, even if there was a large variability. But as they go up, as they become more with more degree of fibrosis, they also have an increase in adipose tissue insulin resistance. And also the abdominal fat is very important in these subjects. And we have previously shown that as a subject, when we divided the subject with low triglyceride, low VAT to high triglyceride, hepatic triglyceride, high VAT, and this was done using a measurement of magnetic resonance imaging, you see how adipose tissue insulin resistance goes up, hepatic insulin resistance measured with the tracers goes up, and muscle insulin sensitivity during the clamp goes down. So this is also to show that there are the importance of both the visceral and the liver fat. And this is also a study from our group that where we were able to measure visceral and liver fat in subject with MASH, with biopsy-proven MASH, and different type of different BMI. You see we had the control that had BMI below 25, but also 3 groups with BMI below 25, 25 and 30 or greater than 30. And, this is a BMI. Hepatic fat, of course, they had the liver biopsy was by definition high. But look at the visceral fat. The subject that had the BMI below 25, they have almost double the amount of visceral fat. And this, by the new definition in this consensus by Lancet, will probably define this subject obese or clinical obese or preclinical obese. I don't know what will be the final things about this, but to show you that is not the BMI alone that we should look. And these, both visceral and hepatic fat, were associated with excess triglyceride, not excess FFA, decrease adiponectic, increase adipose tissue insulin resistance, increase lipolysis, hepatic insulin resistance, increase insulin, and increase muscle insulin resistance. And also, it's very important that it was confirmed that adipose tissue insulin resistance is a marker of fibrosis. And these are two different studies that show this. And this is a study just recently published with measure adipo-ER versus the liver stiffness by FibroScan. And you see how the stiffness goes up, also the adipose tissue insulin resistance goes up. I think this should become also a marker for this disease that is a metabolic disease. And of course, this is the link between adipose tissue and especially the visceral fat and the liver fat. This excess FFA goes into the liver, and we have, of course, is driving the triglyceride synthesis. But what is the impact of on the disease of VLDL secretion? Is it up? Is it down? Is it the same? And also the importance of DNL, de novo lipogenesis. So these are data from the group of Sam Klein and also Margarita Taskinen. And they used tracer to measure VLDL secretion. You see that subject with, at the time they were still calling MASLD, they have a much higher VLDL secretion rate. So VLDL secretion is not impaired, but you see here this non-systemic free fatty acids. So the amount of VLDL, the triglyceride comes from the adipose tissue are the white. This instead is probably part due to the lipolysis, intrahepatic lipolysis. So or de novo lipogenesis or visceral fat contribution that we don't see it. And also it's increased, but it's reaching a sort of plateau. And then there was another study, very interesting, by the group of Elizabeth Parks that went into the composition of this VLDL. And they also look at the contribution of the night evening meal, so the amount of fat in the that was contributing to VLDL and DNL. So you see here in gray, there are the free fatty acid from the white adipose tissue, subcutaneous. The gray is the DNL, and the DNL was like almost more than double, 23% versus 10%. The black is a contribution of the dinner, 5% in both groups, and there was a similar contribution of the visceral fat, or a little bit higher. But when you look at the composition of a VLDL, of course, this is percent and this is absolute, you see like a similar composition, similar contribution of the evening meal, 5% and 5%, but the DNL was double in those with high liver fat, so 23% compared to 10%. But interesting, these two bars are the contribution of free fatty acids. So the free fatty acid, the adipose tissue, is the main contributor of VLDL, and so the triglyceride in the liver. And obesity is associated also with increased DNL, but subjects with obesity have even higher DNL. So obesity and MASLD are associated with higher DNL, and insulin resistance drives hepatic de novo lipogenesis. So insulin, you need FFA, but you need high insulin to make the triglycerides. And so yesterday when I was talking with one of your group, I says like, why DNL is so important? DNL makes palmitate. Palmitate is saturated fatty acid. We know how toxic is palmitate. And so these are unpublished data that we, from our studies, you see that as the subject, as this composition of saturated fatty acid in the plasma goes up, like the first one, it's highly correlated to hepatic fat, so saturated free fatty acid, triglyceride with only 1 or 0,1 double bonds are highly correlated with MCP1, with adipose tissue insulin resistance, with hepatic insulin resistance, while triglycerides with a lot of double bonds, so unsaturated, are negatively associated. So the insulin resistance is also associated with the saturation. But there is not only the insulin resistance and the lipids. these are all going to the liver, and the liver makes glucose. And we know that diabetic have a high prevalence and incidence of type 2 diabetes, actually, of MASLD. Actually, the risk of diabetes in the population with MASLD is over 2%, is 2.2 times, so very high. So glucose metabolism, I will give you a fast, some notion about fasting glucose metabolism, postprandial glucose metabolism, and increased risk of type 2 diabetes. And so this is to show you how glucose toxicity and lipotoxicity are strongly related. Glucose toxicity is usually referred to diabetes only and lipotoxicity to MASLD, but the two are really interrelated. And of course, they all contribute to beta cell dysfunction and also to abnormal glucose metabolism. And of course, there is the fat. Moreover, the subjects with MASLD have high fasting glucose. You see here that most of the subjects are in the pre-diabetes, and also some, they have diabetes, and this is independent of the degree of steatosis. And why is this? Because we have hyperglycemia as a balance. The hyperglycemia is a balance between what is coming to the plasma, that is glucose production, and what is taken up by the periphery, usually, the most is muscle. So you have, when you have high glucose production and reduced muscle glucose uptake, so insulin resistance in the muscle, then you have hyperglycemia. This is well known. And this is why exercise is so effective, that because it's increasing the sensitivity of the muscle. So these are the major causes of fasting hyperglycemia, not only in MASLD, but also in diabetes, in prediabetes. And so to use the tracer, we can measure in vivo in humans glucose production and glucose uptake. And so the same study I was showing you before for the lipids, these are for the glucose during the clamp. These were non-diabetic, but you see that the glucose production is suppressed by the insulin, but not as much as for the control. And the hepatic insulin resistance index is glucose production times insulin is the same things all over, but is because it's the same hyperbolic relationship. You see subject with MASH, they have 30 times higher than the controls. And this is instead the study we just published. So here we were able to see that glucose production is increasing. Even these are all non-diabetics. And you see how glucose production is increased and is increasing with fibrosis. And it does not increase with steatosis. Actually, you see here as that glucose production is not increased with BMI, is not significant increase with steatosis, but is increased with fibrosis and with hepatic inflammation measured in the liver biopsy. That was quite unexpected to have this. I was expecting with inflammation, but not with liver fibrosis. Why liver fibrosis, especially in those that have fibrosis 3 and 4, so are pre-cirrhotics, they should have a high glucose production. So we went and looked, and we found that there was a correlation between HOMA and the glucose production. These are all non-diabetics, as I was telling you, but also was a strong relationship between lipolysis measured with the tracer and glucose production in the same subjects. That was showing that the amount of, this is glycerol arrays, because lipolysis we measure as a glycerol rate of appearance. So the amount of glycerol that go to the liver increase glucose production. Glycerol is a precursor of gluconeogenesis. And so we use these genome scale metabolic models to look at these metabolic intracellular fluxes, and these are based on transcriptomics. And we validated this versus the tracer studies, and these gems are this representation of the metabolic nectar of living cells, and by integrating these gems, we can simulate the intracellular fluxes. So by looking at this, you see we found similar results. This was a much larger population, 206 individuals, all with liver biopsy between diabetic and non-diabetic with different degree of fibrosis. And you see here that the same results that we found for the fluxes, we also found it with the GEM models. There was an increase with the fibrosis and inflammation, and there was, of course, as expected, much higher in those with diabetes. And also the hepatic insulin resistance was increased with the fibrosis, but also was increased with diabetes. So here, to make the slide simpler, we pulled together the fibrosis 0, 1, and 2, 4 for non-diabetic and diabetic. And you see here that we look, because glycerol is one of the precursors of gluconeogenesis. So I learned how to measure gluconeogenesis by Berle-Landau, and we measure it with his method, and we found that the gluconeogenesis was the main driver of the hepatic glucose production. So the hyperglycemia and excess glucose production is driven mainly by the contribution of gluconeogenesis and not glycogenolysis. And also in this cohort, we found that there was an increase as subjects were more fibrotic, and also as they become diabetic, there was a further step in the worsening. And this confirmed a sort of some data that we have looked long before. This was a study in 2007, diabetic and non-diabetic, and you see how gluconeogenesis is associated with free fatty acid. We didn't have glycerol at the time. It's not related to the amount of liver fat. So liver fat, subject with MASLD have high gluconeogenesis, but is not proportional to the amount of fat in the liver, but is proportional to the amount of visceral fat. So probably this lipolysis from visceral fat, the glycerol and free fatty acid that are needed to make ATP for gluconeogenesis are driving the excess gluconeogenesis and glucose production. But also OGDT is abnormal in this subject. These are all non-diabetic. And you see that when we divide it as a presence of obesity or presence of fibrosis, so look at the white, there are those with fibrosis greater or equal to, and the circle are the non-obese and the triangular are obese. Both the white, so the fibrosis, have a higher glucose curve, and of course, have a higher insulin. And when we look at the same subject by steatosis, the curve overlap. So again, there is something related to the presence of fibrosis that is worsening the metabolism. And when we look at the indexes of MASLD insulin sensitivity and the insulin response, we found that the MASLD insulin sensitivity was reduced with the degree of fibrosis in the liver, and the insulin response instead was similar. So the effect of these differences in the curve are just due to the MASLD insulin resistance. And of course, the presence of MASH, these are the same analysis done in another study. When you have MASH, of course, you have insulin resistance, but when you have IGT, you have a decrease in glucose-stimulated insulin resistance, and with MASH, this is worsening. So this is a famous curve, published by many. So you have that a subject progress from MASLD with lean, that are still lean, probably they have a decrease in insulin sensitivity, but they compensate. But of course, as they become obese and glucose intolerant, they also start to have beta cell dysfunction. And then this is the major risk then to have to develop diabetes. I like to finish just to few things for treatment, because we know that I told you that this MASLD is incidental. So right now, what is being suggested by the guidelines is you need to lose weight, at least 5%. The best will be more than 10%. We know it's not easy, and lifestyle changes exercise, of course, but also for other comorbidities. There are several drugs, and you see here listed those that have been suggested by the guidelines, while for MASH with the fibrosis 2-3, these are an indication for the new drugs. Diet plus resmetirom, that is a thyroid beta reception agonist, plus diet and exercise, because has been indication by FDA to add the diet and exercise, has not been approved in Europe yet. Pioglitazone could be useful. Semaglutide, we are waiting for the that has been the are not published yet in the data from the Excel, but has been presented to the ASLD. So just to show you, there is 7 to 10% for MASH of weight loss for MASH and fibrosis, but also consider bariatric surgery in subjects with extreme obesity. And for those with normal weight, of course, 3 to 5% reduction. And the recommendation, diet quality, because it's not only reduce weight, but also change the composition, reduce the ultra-processed fat, and also reduce sugars. Sugars, especially fructose and sucrose, are the drivers of de novo lipogenesis. And so one way is to reduce the fructose and the sucrose. And these are the data that has been published for resolution of MASH with no worsening of fibrosis. These are as I told you, these are not, they're just presented to the American Association for the Study of the Liver. There has been a very nice improvement, 62.9% of subjects that had, this is a phase 3 trial with semaglutide, but also tirzepatide in phase 2 was also effective. And you see the number of subjects are really similar in the highest dose with the SELECT, but of course this is a really reduced number of subjects. And it's interesting to see that they both had weight loss, but was higher as expected with the tirzepatide. But of course, the question will be, is weight loss necessary or the driver for this? Just go to the next one. So another things for tirzepatide, why is working better? So we know it's also effective in reducing visceral fat, not only liver fat. Probably is the GIP, because we know it has a receptor in the adipose tissue. And this one is a slide from a subject with the lowest dose of tirzepatide, the 5 milligrams. So when it's working well. And if you look here, the effect of these are data, these are published. You see there is a nice relationship between the decrease in visceral fat and the decrease in liver fat. And so also there is an increase in a reduction, of course, in free fatty acid and increase in adiponectin. So these are data that has been only presented as an abstract, and the manuscript has been submitted. You see here as the nice dose response in increase in adiponectin and the reduction in leptin with tirzepatide, and also a nice decrease in adipose tissue insulin resistance. Just to slide to finish, because these are the comparison between lifestyle intervention, bariatric surgery for MASH resolution. You see that the numbers are really similar. This is 57, and was for tirzepatide 62, for semaglutide 62.9. This is the dual GLP-1 glucagon agonist, survodutide is 62. But also consider this one, the pampipar, lanifibranor, the pioglitazone or resmetirom. They also have an improvement without weight loss. So weight loss is important, but probably is not the only way. And all these with the error are the one that also show an improvement of fibrosis. Just to finish, only THR beta, so thyroid receptor, PPAR, and glucagon are on the hepatocytes. So the other one, GLP, GIP, have indirect effect because they don't have a receptor direct in the liver. So it's probably the liver fat or other things that we don't know that will act on that. Glucagon instead is very interesting because now we will have the dual GLP-1 glucagon because it has a receptor. It's increasing, decreasing lipogenesis, increasing fat oxidation in the liver. For some reason, it doesn't go up. Okay. And this is the study has been published. This is my last two slides, triple agonists. That will also be interesting because these are the data on liver of retatrutide, the triple agonist by Lilly, and you see like the nice dose response in the effect on the liver fat. So to conclude, I think MASLD is important. MASLD to improve both glucose and lipid metabolism. So not only glucose, improve adipose tissue insulin resistance. Weight loss is probably the most effective way, although not all drugs work on weight loss. And resolution of fibrosis is difficult. Only few drugs and bariatric surgery were able to succeed in it. And I like to thanks my group, and it's a small group, but I like to keep it like that because I want to follow closely all my students and postdoc, and of course, you know, the grant that let me do all this research. Thank you very much for your attention.
Thank you so much, Amalia. That was a fantastic talk. So we have time for questions. Maybe I can start. So you were talking about the interaction between the liver and visceral fat. So what about the subcutaneous fat? I mean, there's also this hypothesis that you have a dysfunctional subcutaneous fat and this causes insulin resistance and the fat has to go somewhere else. So have you looked at that as well? Or how does it work in your mind?
So actually what we measure as lipolysis is 99% subcutaneous fat, because the visceral fat goes, is releasing free fatty acid, adipokines, glycerol directly in portal veins. So I believe that is taken up almost completely by the liver. It's important because even if it's a small depot, it's there and everything goes to the liver. But all the rest that you see around and all the excess circulating free fatty acid are subcutaneous adipose tissue. So the subcutaneous adipose tissue is the one that probably makes the role because if it doesn't expand, then you store fat as visceral or in the liver. But for sure, the adipose tissue, subcutaneous adipose tissue, is the most important. And you see, some subject with morbid obesity that they expand, they have less fibrosis. So it's sort of protective also in that way.
You have some questions from the audience?
They are ready to go to lunch, I think.
Hi, Amalia. I'm here. Amalia?
Yes.
Up here.
Yes.
Good to see you. So I have a simple but also complex question, because you showed during the early stages of type 2 development, we are kind of able to keep blood glucose in a normal range despite being insulin resistant, both in fat and muscle, and also in the liver. So my question is really simply, where does the glucose then go?
You mean the excess glucose?
Yeah.
Well, it should go for sure in the peripheral organs. That is fasting. What I haven't shown today because there was no time is that we also did the tracer during the OGTT. So they do have excess curve. So especially they have an increase in the 1 hour post-load, but then they go back to a normal, let's say, glucose tolerant level. So they usually are below the 200 or the 140. So only some of them, they are IGT. It's more impairment in fasting. And during the OGTT, they tend to secrete, if they're not diabetic, a lot of insulin, and so to suppress glucose production. So the muscle is insulin resistant because of that level is not taking up all the glucose it should be, but I think that until they don't become insufficient beta cell dysfunction, they are not diabetic. So I think it goes to the muscle, but it requires more insulin. It's getting complicated because then we need to go into
simple.
this. Yes.
Yeah, it's simple, but still quite complicated. But thank you.
Amalia. So thank you very much, Amalia. Erik Richter from University of Copenhagen. So I was, it might be related to the previous question, but you had a slide where it looked like the more fibrosis in the liver, the more insulin resistant the muscle is. How do you explain that?
I don't. I cannot explain. I try to. My idea is that probably if insulin resistance in the muscle is first, and then you develop also in the liver, because the hyperinsulinemia is really driven by muscle insulin resistance, and so because especially the muscle is also insulin resistant in postprandial state, and so probably the liver is becoming insulin resistant also as a compensatory things to this excess insulin. You have to keep in mind that there is also a lot of insulin both in the periphery and as a pre-liver, so in the portal vein, because when you measure C-peptide, you see that is increased, even if the hepatic insulin clearance is reduced. That means that you have a lot of insulin secreted, the liver clear less to leave a lot of insulin in the periphery. But my idea is that insulin resistance in muscle comes first, and then the excess insulin is probably driving the insulin resistance in the adipose tissue, or the other things, it could be that because you have adipose tissue insulin resistance and excess free fatty acid, that is compromising the insulin resistance in the muscle, because we know about after intralipid, you impair all the muscle signaling. So that could be the other explanation.
So a quick question here.
Yes.
Hi, Amalia.
Yes.
Good. Thanks for the wonderful talk. I was struck by your slide saying hepatic glucose production is really not associated with steatosis per se, but with fibrosis.
Yes.
But the common dogma is fatty liver is really bad for you, and when you have really severe steatosis, even before you develop a fibrosis, there's a lot of metabolic abnormality, and hepatic glucose production being one of them. So how do we put this all together? What is the metabolic defect associated with hepatic steatosis?
I was expecting a question like that, because you have to keep in mind, and I said at the beginning, that most of the study, they just look at steatosis, and so you have a diagnosis of MASLD, and you don't have a diagnosis of MASH or MASH with fibrosis. So everybody was thinking, and if you look at the great majority of the studies, is just, we measure fat in the liver. So this is just the driver, and then the amount of triglycerides is the driver. It is not, and I think it is just you put fat in the liver because you have excess of fatty acids and lipids to the liver, and the liver cannot clear all of that. It cannot oxidize all of that. It cannot, even if it's oxidizing a lot, so you have that. So this is the first sign. But really the disease is when you have inflammation and then you develop fibrosis. So for sure, some of the previous studies, they didn't really look into the severity of MASLD. They just say it's steatosis, but it's not steatosis. We showed in two different studies now that it's not the steatosis per se. Probably, the triglycerides are neutral. But then there are other lipids. It could be ceramides. It could be the de novo lipogenesis-free palmitate. And it's not the amount, when you measure with also PDFF, MRI PDFF, you measure amount of triglycerides. You don't measure toxic lipids. But the amount of triglycerides is not related to glucose production or gluconeogenesis.
Okay, final last short question,
Thank
please.
you. Very interesting talk. So you said that the bariatric surgery and some drugs are preventing fibrosis. And I remember
resolving from
resolving. Yes, right. So I remember Kirsi Pietiläinen's study. She's been looking at obesity and comparing bariatric surgery and different drugs, and also the dietary decrease of weight. And interestingly, she showed that if you lose the same amount of weight by just dieting, mitochondrial biogenesis is down. Whereas if you look at the bariatric surgery, it's up. And also, I think it was liraglutide probably.
Yeah.
So then I'm starting to think about the fibrosis by itself, because the stellate cells are the ones that are then driving the fibrosis, and they are kind of the astrocytes of the liver. So just thinking that if you then upregulate mitochondrial biogenesis in the fibrosis promoting cells, could that be a mechanism of the resolution of the fibrosis?
I think it could be. And also, I would like to add that remember that fibrosis is a scar after collagen synthesis, and actually is a response to inflammation. And also is not like a constant, but is like going up and down. And so there could be a resolution until you are just up so much so you cannot go back. But insulin is a major driver, because insulin is promoting the collagen synthesis. So I think one of the advantages of the new drugs and the bariatric surgery is that you have a fast weight loss, even extreme, let's say like this. So probably you are clearing the lipotoxicity so fast compared to the diet that you need a lot of time. And so probably this is helping the mitochondria. But I think like for beta cell dysfunction, you probably reach a level where you cannot really improve so much. That could explain why, for example, the people with diabetes, they lose less weight compared to the other one. Probably, you are in a way in which maybe the mitochondria are not enough, not functioning as well. So even if you lose weight, you cannot really improve so much. But for sure, what has been shown that is the fast weight loss, it's really was really driving in the same way bariatric surgery and these new drugs as far as the resolution of MASH.
Okay, so let's thank Amalia once more.
Thank you so much again.
Thank you. That was amazing.